Good afternoon, everybody. Hi, I'm Hugh Porter, GP, clinical lead and interim lead for Nottingham City ICP, and I'm delighted to welcome you to the second Share and Learn of this series. It's great to be able to introduce Dr. Margaret Abbott, a GP at the Wimbledon practice in Snedden, who's also the ICP clinical lead for health inequalities. Many of you will know Margaret, but she's going to sort of tell us all about population health management data and what it means for the ICP. So Margaret's going to talk for about 20 minutes, as we usually have, and then it'll be about 10 minutes for questions and queries afterwards. So please feel free to put questions and queries in the chat box. We'll pick those up and then we can ask Margaret at the end. So without further ado, because time is tight for these sort of share and learn sessions, Margaret, over to you.
Thank you, Hugh, and welcome everybody, and thank you for coming to this meeting today. I hope you'll learn something new about what's happening in the city and our first steps in population health management work in the PCNs. And population health management, of course, is something that the public health have been doing a very long time, and looking at the data across the area, and also GPs and other partners have all been looking at their own populations and their own data for a long time too, and trying to implement productive work and positive work with our patients and citizens. Next, please. So what is population health management? As I say, we've all been doing it a long time, but in particular, there's been a particular focus on it in order to look at the needs of our population, and it's the approach in which data is used to look at the needs of our population, so that the resources can be tailored to where there's going to be the maximum impact. And as well as understanding our current situation and current situations of our citizens, also to predict our future, whether there's going to be more people with diabetes, more people in poor housing, more people who are elderly in the future. And so we can take actions to tailor better care and support and also make better use of public resources. But in the first place, it is looking at the data in terms of the needs of the population, not starting from the point of view of looking at the money and the public resources. And this is a partnership approach across the NHS, but also other public services, as are listed there, many of you who are on the talk at the moment. Next. So already the Public Health Department have, for many years, as their main focus, of course, is health and care service use and resource allocation between our three areas of the ICS, Mid Notts, City and South Notts, each of whom have got roughly 300,000 patients of population, and so roughly equal numbers of people in each area, although obviously sometimes much more spread widely geographically. Next. And the Public Health Department produce information like this in terms of deprivation scores, and the darker the brown colour, the more proportion or prevalence of these issues there are. And as you can see, the city and north and around Mansfield are the areas that have got the most deprivation, and in the city the ethnicity mix is greater there than the rest of the county. Next. But it doesn't all just focus on the city. Also, those that have got long-term illness or disability are focused more in the northwest of the county. And so, and the next point, and emergency admissions again are spread in the northwest of the county and the city, but across the county as well. And when we want to look at services and resource allocation, of course, we will want to be looking at where those pockets are, where there might be more need of the population, more health need and more social need in terms of those long-term illnesses and disability, and so where we need to be directing our resources. And in the long run, we want to be diverting or allocating those resources where there is the most need and most need for services. Next. And again, in terms of mental health, those that have the highest risk of mental illness are living in the 20% most deprived areas of our population, of our county. And so we want to be diverting our mental health resources towards those areas that were the darkest brown on that deprivation map. Next. But so that is the public health approach, and that has stood us in good stead for a long time. But where our focus is now more moving towards health inequalities and also improving the health and well-being of our population, as is this in this statement from the ICS Cares approach to the population health management across the ICS. Next. And so they are looking at now at across the Nottingham and Nottinghamshire, they're looking at the outcomes that they want to achieve and in what ways they could do that. And so these are the ICF's outcomes, which are very broad, which are things like increasing life expectancy, increasing healthy life expectancy, that's life lived healthily before you start to get conditions that cause disability. Other things like increase in school readiness, and increase in the number of people who have the support to self-care and self-manage and become independent. So these are health and social outcomes that are desired by the ICS and which they are trying to move us all towards in the city as well as in the county areas. Next. And their approach is to look for population health management is to start looking at it in this way. So to develop those outcomes, for instance, on number one would be the healthy life expectancy or life without disability, and then develop metrics and measures underneath that and decide what topics. So they are looking at different topics. One, for instance, was diabetes, and then they established particular aspects of diabetes that they wanted to look at, such as reducing the number of people who go blind as a result of diabetes. And then they were looking at the types of interventions that might happen as a result of trying to prevent blindness in diabetics, and the annual checkup for retinopathy for eye checks that is implemented at the moment was looked at. That's a very cost-effective measure, but when they looked at it in more detail, they found that actually those that go every year are less likely to have problems, but those that don't go at all or haven't been for 3 years are the ones that they really need to concentrate on. And so as a result of this, they've looked at those particular cohorts who aren't attending and have decided and put in place some interventions that actually will target those that are most at risk of becoming blind, for instance. And then they plan to look at what they're doing in terms of that and then go back to the beginning and understand what's happening and how they can improve things. So as a result of breaking it down with lots of data, they've actually come up with an intervention that has been proved nationally to be by research that it's an appropriate intervention, but also it's something that can be rolled out across the area. Next. And so the ICS has developed a Systems Analytics Intelligence Unit, the SAIU, and they are producing some very detailed and helpful data and information and research regarding population health management across the ICS, across the Nottinghamshire, including the city. And last year they produced one on diabetes, and recently they've produced one called Aging Well. And those two they are very helpful baselines for which the system can begin to start looking at its population health management. Next. And another aspect that the ICS produced is in relation to the COVID vaccinations, and this really proved the benefit of this type of analysis and data collection. As we began to offer COVID vaccinations to our citizens, we began had to have data produced every week regarding those that were taking it up, in what areas of the city and county they were taking up the COVID vaccinations, what age groups. And then also we began to find certain areas of the city and certain groups in the population were not taking up the vaccine as much as they might have done, or as much as they were doing in other parts of the county. And so that led on to analysis as to what groups these were, and also connecting with local community groups who were representative of those groups that weren't taking up the vaccine. And they were then asked to suggest what might be the issues and how they could co-produce a solution to this. And so the list underneath are the various groups that actually came forward to and be produced as a result of this analysis and this data, which the Black ethnic group, it was found that it was more acceptable if the clinics and the venues at which the vaccines were being offered were populated by people from the same community, and also were able to have sessions there where they could discuss this question, not just a question of walking in and out. Similarly, Muslim faith groups came forward, and 2 mosques were identified in order to encourage people to go from those non-attending populations. And we, City Council customer service team, were involved in calling the non-vaccinated across the whole population. And then communities felt that actually going to your local GP practice, where they were more used to having flu jabs, was the place that some parts of the population would be more likely to go. And again, we put up pop-up clinics for those. And for the homeless and other groups in factories and other groups, the bus was sent round with in order to do vaccinations there. And the Healthcare Trust was involved in the health improvement workers, which were new workers contacting patients about their physical health. They were involved in encouraging people to go for the COVID vaccinations. So as a result of the data and the analysis, that was able to be put forward. Next. So next, please. So the next. So in the city, PCNs as a whole. So that is the situation with the ICS and where we are with the ICS. Nottingham City PCNs, from before the time that the ICS Population Health Management diabetes report was produced, we started looking at the data that had been provided to us in 2019 from the Public Health Department. And they very helpfully put together these health and care profiles. And also we had the very helpful eHealth Scope, which is a kind of a huge database of GP level data. And we have the joint strategic needs assessments from the Public Health on the City Council website, which also helps us with unmet needs and gaps and recommendations for consideration. And so because PCNs in 2020 were wanting to start doing some of this work and working with their populations, they looked at the information from these 3 sets of data and the guidance that's there. And as a result, myself, Tracy Tyrrell and Hussein Mauji, who are ICP leads, clinical leads, we have been working with the PCNs on different topics. So although the ICS reports are now out and are something that we shall be working on in the future, this is what I'm telling you today is what we've started working on before those reports came out, and in order to also work with other community leaders and community groups so that we can tailor our PCN approaches to what is needed in our different populations in our different areas. Next. So what our approach is very similar to the ICS approach in terms of those 6 steps, but slightly modified to be at a more local level and tailored to our PCN capacity. So first of all, what we did with going to the different PCNs was to identify a main topic, to align it with the ICS priority outcome areas, which we've shown earlier there, but also the PCN profile and looking at the PCN performance in comparison with other topics. So for instance, although diabetes is an important topic for the ICS, actually for some areas more cardiovascular disease or child health might be more important for particular PCNs in our city. And also we've asked partners, community and healthcare trust, and also citizens as to what they felt was an important topic in their area. These PCN projects are a very small scale. We're just putting a toe in the water at the moment, and so we are just testing out what's possible, and hopefully we can move forward with bigger projects as we get more experience and confidence and capacity. Next, so after identifying a main topic, then whatever topic it is, can you easily get data about that to measure progress? Can you identify subgroups that need targeting, for instance, those with mental health problems, different languages or ethnicity, or people with learning disability, who might be people who aren't taking up services or who aren't able to provide self-care and improve their health. Also, is there anything that PCN or ICP partners can actually practically do about it? So are the pathways in place that we can kind of feed into? If we were to refer everyone to the Warmer Home scheme, is the capacity in that scheme to take all the referrals? So we have to kind of look carefully at what projects that we're going to be doing if it's going to involve other partners. And also co-designed and co-produced with other citizens, if we can. Next. And what is the evidence of the efficacy of that intervention? So the ICS Diabetes Population Health Report and the JSNAs are places that we can go to look for those particular helpful information about how efficacious it is or how cost effective. And so those are the kind of areas that we would be looking at to look at where we should be putting our efforts. Yes, next. And what capacity, as I said, the PCN will need itself to actually do this. We've got these additional staff roles at the moment called ARS staff. Could they be used? Could other partners have any can help us? Are there any local schemes or a passionate champion who can really drive this forward? So these are all elements which have influenced what the different PCNs have done. Next. And then how will the PCN monitor and evaluate it, which goes back to what data are we collecting at the beginning, and so that we can monitor and evaluate it, and how can we learn the lessons and spread the learning across the city and other areas if our project has been particularly helpful, or learn the lessons if it hasn't. Next. And so just a couple of examples of how this has worked. So for Clifton in the Meadows, for instance, they felt cardiovascular disease was a particular area concern in their area. And when we looked at the data together, we found that indeed they are an area that is an outlier. They have far higher cardiovascular disease than others. And they, looking at this particular set of data in this chart from eHealthscope, Clifton and the Meadows have the highest myocardial infarction heart attack rate in the city and the county, and the line graph at the bottom right shows that it's not just a blip. When we looked at that data, it's a sustained rise over the last year of increasing numbers of people admitted with heart attacks. Next. And so we had meetings with partners to look at the data on various areas of cardiovascular prevention care that are known to be effective and could be changed locally. And some involve just practices, things like prescribing medications and controlling blood pressure. And others involved wider services, cardiac rehab, whether people were going there, whether people were being referred to smoking cessation services. And the group together looked also at the differences between the different parts of Clifton and the Meadows. Clifton and the Meadows are two very different areas with different ethnic mix and different deprivation levels and age profiles. And so whatever intervention that was going to be designed needed to take that into account. Although the practices were prepared to look at the things that they could do personally, to make it a project that was across the community, they wanted to have they decided as a group that the PCN Stop Smoking campaign was something that they felt that they could have the capacity for, and would have the interest and support of the local area and local partners there. And so they identified that there was less smoking cessation services than there used to be, and they have worked to improve local access to Stubbit smoking cessation services, so in that area. And so that's an ongoing project that's well, just started. Next. And it fits into the ICS, many of the ICS outcomes in terms of healthy life expectancy, reduction in smoking prevalence at the time of delivery, reduction in illness and disease prevalence, and so forth. And so that's a project that is fitting in with the ICS outcomes and is something that's kind of evidence-based in terms of smoking cessation does reduce long-term illness and death. But also it's something that the community of partners in that PCN have agreed is the project going forwards. Next. And Nottingham City East, just briefly, we looked at childhood immunisation and nursery uptake, and we have put in place we've been working with Small Steps, Big Changes, and through their application for lottery funding, we got awarded that in order to do a survey of local families from each of those language groups that were particularly families that had low uptake of childhood immunisations and nursery places. Next. And that again fits in with the ICS outcomes of reduction in childhood infant mortality and increase in school readiness. Next. And this is just a list of all the different projects that the 8 PCNs have worked on or are starting to work on, and several of them are around diabetes, obesity, childhood vaccinations and respiratory. Next is nearly there. And
2 minutes, Margaret.
Yeah, sure. And yeah, as I say, the loneliness in the elderly is another topic that is being planned in one in City South. Next. And so the future is we're starting small but learning lessons. Several PCNs as a result of this have made strong links with partners, and we're considering baseline data collection from different partners and what measures can be used. In the future, we hope they might be able to have more support from public health or maybe your research units, and work more closely with that ICS public health management data, those reports that they've produced, because they've got a wealth of information that going forward, no doubt we will be using more of. But at the moment, we're just at the stage of starting small. Next, I think is the last. Yes, and this is for more information. Thank you. Next. Thank you.
Thank you, Margaret, for that and for rattling through that really quickly. Sort of a couple of comments, and I've got a couple of questions, so we'll just take one or two, but I think people appreciated sort of those lived examples, particularly like the cardiovascular disease in Clifton and the sort of smoking side of things, the relation to the ICS outcomes from that point of view. Two little things. How do you think we as can work as a partnership rather than as individual organisations? And I think you perhaps touched on that a little bit, Margaret, but it's often quite easy to pick something up as an individual organisation, but to do it as a partnership is a little bit different. I wonder if you'd like to sort of respond to that.
Yes, of course, this is all very health focused, isn't it? And the data that we've got the most detail on and the most access to is health data. The ICS outcomes are mostly in relation to health and healthy life expectancy and so on, and only 2 of them are partly related to the more social or education. But as I said in my previous talk a few months ago, of course, healthy outcomes are related to housing and crime and education and all sorts of different topics in our community. And so it's important really for us to start working together with our partners to help. The example, for instance, of the people with respiratory conditions are worse if they have cold, damp homes, might be an example, or where we could work together more with our partners who are not from health, and also likewise those that are on long-term sick or unemployed, how we can help get them into access to work schemes. But if we can get in the PCNs, we're trying to pull together groups in PCN 1 and PCN 6. We're trying to pull together some steering groups where they will have different partners so that they can have their input as to what aspects of the projects that are being proposed can affect them. So I think the way forward is really to be working together at a local level and trying to pull together some of that data and understand the priorities of those different people.
Thanks, Margaret. 2 sort of things a little bit linked. So where can people learn more about eHealth Scope and these PCN profiles? And then there's another sort of perhaps linked question. You mentioned the, I think, System Analytical Information Unit. How have you been using that unit for some of this work, or can they help you, do you think, or help people on that side of things?
So on the last but one slide, I've got a list of references, so that has got on there the link to the PCN profiles. So that is publicly available through the ICS website. So if you go to the ICS website and then drill down into the primary care networks, then each primary care network has got the health and care profile for that, and that's also on the Insight. That's linked from the Insight City Council. In terms of going forward for the SAIU diabetes and aging well reports, for instance, I think there needs to be more promotion of those at PCN level or system level. I think most PCNs aren't very well aware of those, and I think with all the other things that they've had to do, and I think going forward I would like to see us working much more closely with them and working out how to put in place those implementable projects that they are proposing there. At the moment, I don't think they've got high enough profile, but going forward, I would really like that to be the case, that we would, when the report comes out, we look at it in detail in each PCN and decide at those multi-agency groups how exactly we're going to be implementing that in our PCNs.
Lovely, thank you, Margaret. So we've had our half an hour. We like to keep these on time because I know everybody's really busy with their day jobs. So just to say common things, we will sort of share the presentation that will be available online for people, as will be a sort of copy of the webinar from that side of things. So if people want to look at it at some point, they can go back to it. And as I say, on those slides will be contact details, as ever with the ICP. If you have any queries or questions, equally, if you have ideas of stuff to go for the show, and then just get in contact with us. We're delightful to have a conversation. But can I again thank Margaret for her time and efforts, both in doing this, but also this work she's been doing with this population health management. It's a new way of working. It's taking us a little while to, I think, get there, but actually it's a real opportunity to do things in a slightly different way. So thank you again, Margaret, and I wish everybody a good afternoon. Thank you and take care now.
Thank you.